Hello, and welcome to our program, Empowering OBGYNs Leading the Way in Postpartum Depression Care. I would like to introduce faculty members. Faculty members Dr. L. Joy Baker, an obstetrician gynecologist from LaGrange, Georgia, and Dr. Cipralata, co-founder of LunaJoy, adjunct professor of psychiatry at Emory University School of Medicine, and psychiatric consultation line advisor at Postpartum Support International in Brookhaven, Georgia. Thank you for participating in this accredited activity. You can access the CME information for this activity, including details on how to claim credit via the QR code that appears at the top of your screen or the link that is posted in the chat box. A link to our resource page, which includes all journals we will be discussing today, can also be found in the chat. Please use the comments to submit any questions for our presenters. I will now turn it over to Dr. Baker to start the conversation.
Fantastic. Welcome, everybody. I am absolutely elated to have the opportunity to have this conversation among colleagues. I think it's so important and very timely. I'm so pleased to be joined by Dr. Cipralata for us to just have a moment to chat about postpartum depression and how we screen for it, particularly. This is part one of a three-part series, so we hope that you'll join us for the other two portions of this conversation. The information provided through this activity is for educational purposes only. We're not telling you how to practice, and we're just providing some general guidelines. Here are our disclosures. And be sure to scan to get your CEs or CMEs prior to logging off of this presentation. It's 0.5 credits. So welcome to our Journal Club discussion today. We're going to be talking about screening and diagnosis of mental health conditions during pregnancy and postpartum. So I hope that you guys will engage with us in the chat. If you have questions, pop those in there. We would love to engage with you today. And once we complete this 30-minute conversation, participants should be able to integrate best practices for screening and interviewing their postpartum patients for depressive symptoms. This talk is really, really personal and important to me because while I had really mastered postpartum hemorrhage and OB sepsis and DKA in pregnancy and all of these other management of high risk pregnancies in my small rural town, I had not learned a lot about perinatal mood and anxiety disorders. And so, about a decade ago, I had a patient who had all the things, right? She had diabetes and hypertension, sleep apnea, and class 3 obesity. And so, I was really, really concerned about making sure that all of her numbers were just perfect in terms of her glucose management and her blood pressure management. But unfortunately, postpartum depression just wasn't on my radar. And while she delivered safely and we were able to get her home and her baby went home and they were both healthy, she eventually spiraled down into a deep depression and ended up ending her life. And so when I talk to my colleagues about this, to other healthcare professionals, it's very personal for me. And so I hope that we can engage in a conversation about this today that will encourage each of us to always have perinatal mood and anxiety disorders on our radar when we're dealing with our patients. Because as you can see, some of the top causes of maternal morbidity and mortality is actually mental health conditions. The CDC placed these statistics out, and you can see that substance use, overdose, suicide are actually the number one killers of moms in our country. So it's so important that we as physicians, midwives, nurse practitioners, PAs are really screening our patients and making this a very integral part of our practice. So if we look at postpartum depression by the numbers, or perinatal depression is how I like to refer to it, 1 in 5 pregnant people is going to have a mental health condition. And if we look at patient data from a sample of pregnant participants who had public and private insurance plans, we found that that only fewer than 20% of these patients were actually being screened with a validated screening tool in practice. And like I said, many times it can sort of fall off our radar when we're thinking about all the other things, screenings and things that we do during the perinatal period. So it is up to us to identify risk factors in our patients. So folks with perinatal mental health conditions can have biological risk factors, if they're younger in age or older in age on that spectrum of childbearing years. They can have predispositions that are genetic. So, these people may have family members that have suffered from mental illness in the past. Folks who have poor physical health often can have poor mental health as well. And, not feeling well can certainly affect your mental health. So if you've been going through a lot of health challenges, you can sometimes develop depression and anxiety. Hormonal imbalances, immunologic factors, and sleep disturbances, as well as substance use disorders, also pose biological um, risk factors for patients. And then, of course, we all have our psychosocial needs. So, if we have a lack of support, if we intended this pregnancy or not, if the patient has poor self-esteem or coping skills, if there are family histories of behavioral issues, discrimination based on race, gender, or ethnicity. Sometimes folks who are active duty or veterans may have challenges. People who are dealing with money issues or lower education or health literacy levels. So many, many factors can play into perinatal mood and anxiety disorders. So, what I would like to sort of shift the conversation to at this point is to talk a little bit about some of the commonly used validated screening tools. And, the when we're talking about the screening tool, we are looking for a specific condition, such as depression. So, during the perinatal period, the Edinburgh Postnatal Depression Scale is certainly validated for these patients, and also the PHQ-9. I use the Edinburgh just because in my practice, I'm able to get a little bit more bang for my buck, but there are lots of scales that are available out there. With anxiety, the Edinburgh sort of touches on whether or not patients are experiencing anxiety or not in questions 3, 4, and 5. But then there's also the generalized anxiety scale, or the GAS-7, that can be used, or the state trait anxiety inventory as well. And then certainly if you have patients who you are planning to treat for depression, you might you should consider a bipolar disorder screen as well. And you can do that with the MDQ or the Composite International Diagnostic Interview. So these are all screening tools that you can easily implement into practice. So if we're talking about suicidality and folks who are expressing suicidal ideation, we should definitely ask more questions. Like, have they had these thoughts in the last 2 weeks? Are they wishing that maybe they weren't here, or they are thinking about death? We should ask them about whether or not they have a plan. Have they thought about ways that they could hurt themselves? And, asking too if they have history of a suicide attempt or suicidality in the past. And what things sort of ground them to life? What prevents them from acting on thoughts of death or wanting to die? And so, while these validated screening tools are certainly really valuable, I think it's important that we focus on the fact that we're treating patients and not numbers. You may have a patient that screens negative or borderline who may actually have some significant challenges in terms of their mental health. So, maybe you have a patient that you're concerned about. I think it's always appropriate to have a conversation with the patients to ask them, even if I review their validated screening tool, I'm still going to ask my patient, like, how are things going? How do you feel things are going? Do you feel like yourself? Do you have enough support? So, just sort of opening the conversation is very important because many patients may screen positive but decide not to engage in follow-up care for a variety of reasons.
Mhm.
And so there are, the barriers are not always just related to access to care. Sometimes they might be cultural, they might be behavioral or contextual. And so effective care is going to require understanding how patients perceive the screening and maybe screening positive with one of the screening tools. And so intentional engagement around the results of the screening tool is so important. And it's also just the rapport with the patient, right? So when we're able to really hear from that patient, to listen to them, to help them with screening and brief intervention and then referral to treatment if needed, that just helps us to build the rapport better with the patients.
Yeah,
And
and Dr.
so,
Baker, I just want to
understanding the engagement through the COM-B model is something that has been very helpful for me in my practice. And so, we know that patients engage based on their capability, opportunity, or motivation. So, being able to help them connect with the fact that they are very capable, that you're offering the opportunity with access to care, um, and having time to talk with the patient, making it a culturally safe space, and then helping them with motivation. They need to trust us, and we need to help them remove stigma. So I'm going to hand it off to
yeah.
Dr. Lotta here to continue on how she engages with patients who are coming in.
Yeah, absolutely. Thanks for that handoff, Dr. Baker. And I just want to emphasize something that you had mentioned on a previous slide around screening for suicidality. So as a psychiatrist, it is really important, and I think it can be
Dr.
very,
Lotta?
yep. Can you hear me? Can you hear me? Dr. Baker, can you hear me?
We seem to have lost Dr. Lotta for a second here. So I'll keep.
So it looks like Justin can hear me. So I'm going to jump in, and Dr. Baker, if you want to maybe try just closing out
Now I can.
again. Okay, awesome. Dr. Baker, what I was going to say is I wanted to reiterate something that you had just said in a previous slide around screening for suicidality and talking about suicide. And certainly as a psychiatrist, it's something that we're used to doing all the time, but can be often difficult in an obstetric setting when you're not used to having those.
I can hear you now, Dr. Lotta.
Perfect. And so what I think is really important around screening for suicide is just not being scared to ask those questions and asking in a matter-of-fact way, and giving patients time to give their answers regardless of what those answers are, because sometimes, especially in medical settings, patients are very hesitant to talk about thoughts of not wanting to be here or suicide, and then there are multiple levels of that
I
as
can hear you now. I think that everyone else is hearing you. So go right ahead.
great. There's also just multiple levels of suicidal ideation, right? So assessing whether or not people are suicidal, but even asking more basic questions around what is your what are the things that you want to live for, and even if you don't necessarily feel very depressed or you feel like you want to end your life, do you sometimes feel like living is painful or that it's not worth being here? And so suicide can be asked about in lots of different ways and with different questions in order to really understand how people are feeling. So I love, Dr. Baker, that you went over screening for suicide, because it's really important, especially in our perinatal population. I also want to reiterate something that you said on a previous slide, which is that sometimes even when patients are screened and their screening scores come back positive, it does not always mean that they're going to be able or willing to engage in care. And sometimes that's certainly a access issue, but a lot of times there's a lot of stigma, there's judgment, there's also just lack of information and knowledge as to what care looks like, what therapy could be like, what medication potentially could be, how it might be helpful. And so patients really do report a higher willingness to engage in care when we start off these screening conversations in a way that's very non-judgmental, when we make normalizing and empathic statements, even giving patients the statistics around perinatal anxiety and depression, so that when people are starting to endorse some of these symptoms, that they know that they are not alone, that this is something that you as a medical provider see often. And so providers kind of explaining why screening matters, not just that it's a required thing, not just that we're, here to tick boxes, but that it matters how mom is feeling. It matters what her experience is. Even if baby is thriving, it really does matter whether she's feeling happy, sad, depressed, anxious. And then making sure that the follow-up options are very clear, immediate, and personalized is really important. Even though it might seem obvious to us that if someone has a high screening score and if they're feeling depressed and anxious, that they should get treatment, whether that's therapy or potentially medication management or a psychiatric evaluation, that is not always clear to patients. And so making sure that we are actually saying next steps here with a positive screen and from everything that you've discussed with me is potentially following up with a therapy appointment and or seeing a psychiatrist for potential evaluation for medication, saying things like, I would like for you to do this sooner rather than later. It is really important that we're treating your mental health just as urgently as your physical health, and then giving a personalized recommendation. So typically giving names and numbers of many, many people from the office manager is checking the box, and we're giving people resources, but it's often not personalized. And what we know is in those settings that a very low percentage of women with positive screens actually pick up the phone and outreach a number of those people on referral lists. And so typically recommending or referring to a specific place, providing care coordination, those are all really important things. And then finally, it's just very important to remember the cultural context and explicitly acknowledge that this is a life stage, that these things are common. And the other thing that we want to talk about is that it is highly treatable. So oftentimes when people are feeling very depressed, they feel like there is lack of hope. They don't think that there is a way to get better, and they certainly don't see or have the tools in order to get better. And so explicitly stating that this is something that is treatable, this is something that can improve, is really important. So translating evidence into the obstetric practice. Best practices for perinatal depression and anxiety care include routine and repeated screening across pregnancy and postpartum. That often looks like screening at least one time during each trimester. And certainly for patients who are already coming in with a history of anxiety, depression, or other mood disorders, we want to be doing anticipatory guidance as early as possible and giving the information early, and certainly following up with these screens. We want to make sure that there's a clear response pathways for positive screens, because while many practices have certainly implemented ACOG guidelines and standards for screening, what is often the missing gap is what happens when that screen is positive. Is there a referral pathway? Is there a referral pathway that actually has a loop back to the provider? Is there a referral pathway that if the patient does not pick up the phone and call a referral, that we are catching that at the next appointment and continuing to encourage them to engage in care? And then using team-based models where we integrate behavioral health support, getting information back from behavioral health providers, sending information to behavioral health providers to really give that patient that feeling and that understanding that the medical care and the mental health care is really coming together, and it's all part of the same, that these are not two distinct entities that have nothing to do with each other. And so what we know really is that structured systems, empathic communication is what accounts for safer maternal outcomes. So again, just to reiterate Dr. Baker's instructions here, certificate instructions, zero point 0.5 credit CE activity, you can go ahead and scan the QR code. And I think we do have a little bit of time for question, answer, and discussion now, and I will open that up.
Dr. Latta and Dr. Baker, this is Jamie from MedIQ. We had a couple questions submitted on the resource page. The first one, someone asked, how early do you start screening for postpartum depression? Is that something that should be happening during the pregnancy visits, or what would you recommend for that?
So for me, I'm going to start screening even at preconception visits. I think it's something, it's a part of a holistic framework for making sure that patients have good outcomes during their pregnancy. And there might be things that we need to work on or optimize prior to pregnancy. So I don't think that there's any time that's too early to start screening, right? So I will screen at preconception. If the patient arrives and is already pregnant, then I'll screen at the initial visit. And I screen at the 26 to 28 week glucola visit because we already have them captive for an hour anyway, and
Mhm.
that's right at the start of the third trimester. And then we screen before the patient leaves the hospital. That's just a part of our hospital protocol. That way we can sort of identify those patients that we certainly need to follow up with in 1 or 2 weeks just to see how they're doing. And then we screen, of course, at the postpartum visits. And we have 3 postpartum visits that are scheduled for the patients. And we screen at each one of those. So my patients get a lot of screening. And I think that it also helps to normalize it because they're like, oh, I'm coming to the doctor, I'm going to get screened. So I think that really makes it normal. And that gives us a lot of opportunity to talk about how they're feeling and how they're really doing.
Yeah. And to jump off of that, Dr. Baker, also want to emphasize that what we often call postpartum depression is actually perinatal depression. And what we know is that 60 to 70% of people that develop symptomatic postpartum depression, that they actually have symptoms during pregnancy. We're just recognizing it in the postpartum period. Often when we have this perfect storm of hormones and sleep deprivation, that's when it becomes kind of like clinically recognizable. But 60 to 70% of those people are going to be symptomatic during pregnancy. So I agree it's never really too early, but at least every trimester.
Great, thank you for that. I have a couple more questions from the resource page. The next one, how can a clinician be culturally responsive when discussing mental health conditions with patients?
I think that the patient's cultural beliefs belong in the room. And I think sometimes the humility to just ask, are there things, cultural things I should be aware of? Like, for instance, as a Black woman, you know, when we talk about mental health, a lot of my patients are say things like, well, I'm going to talk to my pastor. I'm just going to pray about it, or I'm going to talk to my auntie. And so there are certainly there is space in the room for all of that. And my job as a clinician is to sort of offer access to as many tools as possible for that patient. And I always say, I'm a Black woman living in the South, so I talk to them about that. Yeah, it is certainly okay to pray and journal and talk to your grandmother, or your aunt, or your mom, or your sister, maybe even your pastor. But there is a subset of folks who are trained professionals that can also help with this. So why don't we avail ourselves of all of the tools in our toolkit? So, to sort of just start to suggest that. But I think sometimes just asking the question about how that person views this positive screen or going to treatment, like how does that look to them, how does that feel in their community, because I think a lot of times we don't think about that. We just sort of get focused in on these numbers and what we're going to do to treat the patient.
Mhm. Yeah, completely agree with everything that you said. And I think building off of that as well, just asking them how they feel about the recommendation can be really eye opening, right? So sometimes we're talking to them about the screen and the fact that it's positive, and, in our medical world, 1 + 1 = 2. And so they should go off and get treatment. But saying something along the lines of, I think I would really recommend at this point that you either engage in therapy or that you have an evaluation. How do you feel about that recommendation? And so that they can start to open up and say, well, in my culture, we don't do that, or everyone's going to think I'm crazy, or whatever those thoughts are. But just all the different ways to really get them to engage with you and start to develop that rapport so that you can understand better where they're coming from, what their barriers might be, and help to get them to that next step.
Yeah, I totally agree. And sometimes it's not necessarily race or ethnicity, but it's small town culture. I practice in a small town, and oftentimes I'll have folks saying, "Oh my gosh, I don't want people to see my car at the
Mhm.
mental health clinic. I don't want the pharmacist knows my parents. I don't want them to know that I'm taking an antidepressant therapy." So there's lots of things that can become barriers that we need to understand from the perspective of the patient and how we can better assist them in getting the help they need.
Right. Thank you both for your responses. I have one additional question. How should a clinician manage screening when a support person has made comments that hint at the presence of maternal depression, but the patient is non-responsive to screening attempts?
That's a really good one. I would love to hear how you handle that one, Dr. Latta. I can tell you what I do, but it might not be the most politically correct thing because I have real life conversations with my patients. We have, heart to heart, and we got to break out the tissues and cry it out. We do that.
Yeah.
And I think that some of that may be my own trauma from having lost a patient who, died by suicide. I really take it seriously when someone comes, and I got a text Thursday from a community person who said, "Hey, I saw this person out and they're acting way out of character. I think you need to talk to them." And so I hunted this poor girl down and said, "Hey, we need to have a conversation." And
Mhm.
before I could even start talking, the tears just started flowing. And
Yeah.
so I think sometimes people really need you to know that that you really do care about them and you want to help them.
Yeah, I agree with everything that you said. And I think that, oftentimes people are quite defended. If you think about someone experiencing depression or anxiety, it takes a lot of work, mental work to get through the day, to keep it together, to go to appointments. And certainly, answering negative on a screen is a way of protecting yourself, often if you're just trying to manage your internal experience and your internal life. And so I think one way is really just calling attention in a very compassionate way to that discrepancy. So we see this all the time in psychiatry where, a family member, someone is very concerned and giving us information. We're talking to the patient, and the patient's like, "Nope, that's not me. Don't need anything. I'm totally fine." And so just very gently kind of bringing this to them, which is like, it seems like your husband is pretty concerned that you're not acting like yourself and that it seems like things are off at home. And, here you didn't answer anything on the screen that's suggestive of that. What do you make out of this idea that he, is noticing that things feel off? And so that's a very non accusatory way of just giving information and having them kind of piece together the information. Some of it can also just be insight on their part. And this also helps to increase insight, which is like, okay, well, other people are noticing this. How do I make sense of that? Is there something actually more going on? Is there something that I can sit and think through, or like at least start to have that conversation? So I usually very like empathically will bring up discrepancies between patient report and family report and ask the patient to think through that with me and tell me, what their thoughts are about that discrepancy and why it exists. And that can start the wheels churning around having the discussions that are really important during this time.
Great. Thank you both for your responses. I'm not seeing any other questions in the chat. Again, if you have any questions you would like to ask, please post those in the chat for us.
It's okay to post a question. Don't be shy because we are here to engage with you. That's why we came today.
Okay, I think that might be it. Dr. Lada and Dr. Baker, I'm not seeing any more questions. So I think we can wrap this up. And I just wanted to end by saying thank you to both of you for joining this discussion today and sharing your expertise with us.
Fantastic. Just remember, screen early, screen often. It's my golden rule.